uh, GECO session, which is hosted by the Gastro Foundation and so in association with Project ECHO, the University of New Mexico. These sessions are held on a weekly basis. Today's discussion is the title is Personalized Medicine in Current HCC Guidelines with Case Discussions. Professor Jonas is going to speak about personalized medicine in the current HCC guidelines, and then three of our fellows, Pacifico Pai, Dominic Matura, and Melini Barna, are going to each just present a case that we can chat about. Okay, thanks. Ed, over to you.
Thank you, Mark. I'm just going to share and see if it works.
Yep, that's working.
Okay, great. Thank you very much. Okay, thank you very much for the introduction, Mark. So I thought we can just go through the guidelines before we go into the case presentations and specifically look at the personalized medicine in the treatment of HCC. So if we go back in time a little bit, and this is just the two references, is that the first time the Barcelona criteria were published was in 1999. At the same time, there was actually a short article in the Wall Street Journal that highlighted a new era of personalized medicine that was subsequently published in the Oncologist, and I think that was the first time that the medical fraternity was exposed to this sort of kind of a new term. So if you look at guidelines-based versus personalized medicine, they seem to have slightly different purposes or views on how patients should be treated. So guideline-based medicine is really to provide a structured, evidence-based approach to the diagnosis, treatment, and management of diseases. And the aim is actually to ensure consistency in clinical practice and reduce any variability in healthcare. And if you look at personalized medicine, also called precision medicine, although there's a slight difference that I'll show you, it's really about tailoring management decisions to the individual patient's characteristics, and it's based on a deep understanding of genetic, molecular, and clinical variability in patients. And the aim here, it seems a little bit as opposed to personalized medicine, is to develop a more individual, targeted, and hopefully more effective treatment plan. And then just there are slight differences between personalized and precision medicine, but I'm not going to dwell on that. Personalized medicine, well, the big difference is personalized medicine sort of it's got a broader focus, and it doesn't only take in account treatment, but also include prevention and diagnosis, whereas precision medicine is very much more focused and relies quite heavily on genetic and omics data. So we know that the global burden of HCC is quite high. It's the fourth leading cause of cancer-related death and the sixth most common cancer. The highest incidence are on our continent and also in Southeast Asia. And then sort of just in general, it's driven by these quite well-known etiological factors. So if you go to the first edition of all the guidelines, and you can see here, I don't put the Barcelona guidelines in because they basically form the basis of EASL, ASLD, and the WHO guidelines. But interestingly, you'll see that the NCCN guidelines and most of the Asia Pacific guidelines, also for the different countries, don't even mention the Barcelona criteria, but they're basically identical with very small differences, looking at the performance status of patients, in other words, to see whether they will be fit to tolerate whatever treatment we plan for them. We look at surrogates for liver function. And again, we're talking just about surrogates because none of the things that we look at actually accurately measure liver function. And then we look at the tumor burden in terms of size, number, and vascular invasion. So we know that HCC is not a uniform disease. There's a wide variation in etiological factors, varying clinical presentations. We know that at similar stages, there's a whole spread of different prognoses in patients, and there's also a global variation in survival that we are very well aware of. And just the fact that on the current treatment guidelines, where we very much rely on, if it comes to tumor factors, the size and the number, clearly there's a link missing here because patients with exactly the same tumors, similar liver function, have got very different outcomes. And I think that is where the whole field of omics comes into. It's not my specialty, although I know a little bit about that, mostly due to Sanju Sopna's research, but it covers quite a large um, sort of spread of different omics that you look at, and I've listed them there for you. So if you look at the latest editions of the guidelines, again, the 5 there, you can see that there's absolutely no omics data or personalized or precision medicine guidelines of any sort still in the guidelines. They all acknowledge, sort of with different statements, that it's going to be important for the future, but there's really still nothing where you would make decisions based on actual omics data or genetic data for that matter. We can just look at the different treatment modalities, and I'm just going to say a few words about resection and transplantation, and also the systemic therapies. So we know that we still base our liver resection decisions on tumor characteristics, function surrogates, and also the general condition of the patient. Suffice to say that we know that these are very conservative, and I think almost all units, and certainly we do operate patients outside of the Barcelona criteria that will, at least in Africa, make very few patients eligible for surgery. This is a very interesting study that was first published by Young et al. Is the latest one, but by Singh first, where they divided patients by Young was first. They divided, this is early HCC, into 3 subtypes, S1, S2, S3, where they looked at proteomics. And you could see here that they showed a statistically significant difference between the S1, S2, and S3 groups. And that was repeated by Gao, by another guy called NG, and then Xing as well. And you can see here they looked at the overall survival and also at the recurrence-free survival. So what they've done is they've looked at the whole panel of proteins, and they have correlated the S1 to 3 classification with other indicators of survival. So it did correlate significantly with AFP, with microvascular invasion, with the number of the tumors, not the tumor size though, with TNM stage, BCL stage, differentiation of the tumor, and then also whether there's a tumor capsule present or not. The complexity of introducing any of these into the guidelines are many. And if you look at AFP, so AFP is a protein, it's been known for years, but that is still not consistently part of the decision making, although we do consider it, for instance, in transplant. If the values are very high, we want to get it down before patients are transplanted. And we've got sort of a little bit the same approach in patients that we resect, that if patients have got very, very high AFP values, that resection may be futile in those because there's a high risk that the tumor has spread. But the complexity of omics, and in this case, the proteomics, you can see that in the S1 to 3 study, the signatures that they use contain 1,200, 1,270, 761 proteins. And to assess every one of those every time to make sure in which category the patient falls is really a problem. And with machine learning, they've seemed to have reduced it to 9. So it makes it a little bit more closer to what could be clinically applicable. If you go to liver transplantation, current decision-making still based on tumor and number and size. We do look at AFP. And if you go to the Toronto criteria, they ignore size and number mostly, and they would look at the differentiation only. And if patients are not poorly differentiated, they could potentially be candidates for a transplant. There is some omics, a single article I found that basically just had a diagram where they said how omics may be applicable in transplant in the future. looking at a donor sample as well as a recipient sample. If we look at the systemic therapies, these are on the current guidelines, and you could see here that they all agree, EASL, ASLD, APASL, NCCN, and partially the WHO, that the first line treatment should be the doublet treatment with atezolizumab and Avastin, and that should go first for patient treatment, then comes sorafenib, then lenvatinib, and then the others here. And the only one actually where there's any sort of personalized or precision medicine applies is for ramucirumab, where only patients with a AFP level of more than 400 actually should be eligible for that treatment. And then again, the WHO that is very cognizant of resource limitations. You can see here only shows sorafenib and lenvatinib, and as you will see, we still have problems in getting those. I mean, it is quite important, I think, the omics data. These are the different or the most prominent cancer pathways for HCC, and it seems like that the importance are kind of ranked depending, in this case, whether the livers are non-cirrhotic or cirrhotic. It's almost just turned around. The same in HBV-related and non-HBV-related research. You can see that whether patients have got HBV or not it does seem that the cancer pathways have differential importance and kick in at different times. So we really have to look at cancer in the context, and we're thinking about sub-Saharan Africa, where most patients are non-cirrhotic and most of them are HBV related. That clearly doesn't follow the pathways of the normal cirrhotic pathway that you will see in high-income countries. I'm just going to skip that just to show you that the survival is still terrible. In sub-Saharan Africa, you can see here median survival of about 3 months, and really still a big problem. The problem is that if we do not pay attention to what is happening, the discrepancies and the differential means of treating patients is gonna keep on and carry on in the era of, I think what is going to happen now is a personalized precision medicine algorithms that are hopefully pretty soon are going to be included in the guidelines. And if we don't address those, it really will be problematic, and we will still be at a disadvantage compared to high-income countries. There's a little bit of omics data that I got from Sanju about that we've looked at. Quite interestingly, and this is in a study where he included about, I think it was about 80 patients, 90 patients in the two different groups, HCCs and controls. So controls were patients that did include some cirrhotics, but not with the HCC. And you can see here that there were very clearly two main groups of tumors. So you can see here the controls are little triangles, and non-cirrhotic, cirrhotic. So there were cirrhotic controls as well. And you can see the cirrhotic controls are together with one of the groups of tumors that you find there, and then non-cirrhotic tumors in that area there. I'm just going to skip that. We also looked at some of the metabolomics. Two things we looked at is 2-hydroxybutyrate and creatine, that in this proteomic study that he's done, it seems to have quite a strong prognostic value in patients with HCC. I'm not going to show you pictures because it's going to take some time. But we've also done a project where we use the Hive technology, where you in the field basically can just do biopsies and put it in this small little Hive culture cell where the cells are split up and tagged. And we have now done, I think it was 8 of those, and you can very clearly see many weeks after the harvesting of the cells, very well preserved cells. And this gives you an idea of the different cells that you find in these in the biopsies from the tumors that we've entered into the study. So just to conclude, I think there's an imminent departure from purely clinical baseline guidelines, or at least I think there should be. There's still a lot of challenges that we will have to overcome. It's certainly not impossible to overcome, to make sure that it also becomes relevant to our patients. And the policy, the whole advocacy thing we've spoken about many, many times, that we're not going to win this battle. We'll have to look at the global medical community, policymakers, and also industry stakeholders to help us in this. Thank you very much.
Thanks very much, Ed. I'm not sure if there's any questions. You can put questions in the chat, or you can raise your hand. You can also, if you think of any questions, ask them just now or after the next talk. So if there's no questions, we'll move on to Pacifica Pai, who's going to just present a case that we recently managed. Pacifica? I think we're just having a little technical problem. We'll just try to sort it out. Just give us a minute. Okay, here we go. We can't hear you guys. I think you might be muted.
Can you hear me now?
Yeah, that's better. Okay.
All right.
Thanks, Pacifica.
All right. Thanks, everybody. My name is Pacific. I'm one of the fellows in HBB UCT. I'm going to present one case that we had here in our unit. It's a young lady. She's 24 years old. She's a school teacher with a good performance status, of 0. Clinically, she presented to us with right upper quadrant pain for about 3 weeks. She was seen previously in private and was referred to us to Groote Hospital. Otherwise, previously she has been well. She doesn't have any medical comorbidities. She has a very strong family history, though. Her mother died of HCC some few years back. On examination, she had a tender right upper quadrant. She was not jaundiced. There's no signs of chronic liver disease. She didn't have any ascites. Investigation-wise, she's HIV negative. Hep B surface antigen was positive. Hep core antibody was positive. She has hepatitis C was negative. And she has an alpha-fetoprotein of around about 15,000. CA19.9 was 1 and CA was 0.8. Child Pew A5 and a MELT of 28. Her UNEs were normal. She has a total bill of 6, and if you look at the gamma GGT, was less than 800. This is a CT scan that was done on her when she came to us. If you look at the arterial face, comparing it to the venous face, these are the high cuts in segment 2, 4A, 8, and 7. You can see there's no tumor on those. And as you look here, the portal vein is completely patent and not involved. When you come down to the cuts, you can see tumor around segment 5, 5 and 6. It's a hypervascular with a complete washout of contrast in the delayed phase. She has a non-cirrhotic liver. This is just a cut from a CT scan that was done when she came to us, but this one was a MRI that was done previously in private, and you can see the tumor is mainly confined down here around segment 5 and 6, and the vessels are all not involved. And the tumor is quite large. It's more than 9 by 9 centimeters. So she was discussed in an MDT meeting, and the plan was to go forward with the right-sided liver resection. Concern during that time was that AFP was quite high. Decision was made to proceed with just to test tumor biology before we offer her the resection. So she had her first test on the 2nd of September, and there was a marked interval change, reduction, in the AFP from 15,000 cuts down to almost half, which is 7,000. So the plan again was to test her again, and since the AFP cut down significantly, and with the hope that we go for resection. And this is the second test, and she had second test. With the second test, she has portal vein embolization and hepatic artery deposit at the same time. And these are some of the coils that were put in by our radiology to show the team. But you can appreciate the portal vein is completely patent, no tumor in vein. These are some of the axial cuts, and you can see the liver has hypertrophied markedly on the left lobe of the liver, hemiliver. So she had a staging CT scan just about a week ago, and the staging CT scan has shown that the tumor has increased in size. So the initial one was 9.8 by 7.8 centimeters. But on the staging, the tumor has increased to 10.8 by 8 centimeter. There was a question of whether there was a portal hepatis node by our radiology, but they were not 100% sure. And there was no lung or extrahepatic metastasis. She was taken to theater. Actually, she was taken to theater today. She had a laparotomy. Some notes were found, sent for frozen section. Those notes were negative. Surgery was, they proceeded with surgery to do a right hepatectomy. These are some of the pictures just from theater to appreciate the tumor. The tumor looks like more like aggressive kind of a tumor, fungating in nature, the way I see it here. And this is the specimen from theater. And this is after the tumor has been resected. Thank you very much.
Thanks, Mr. Figo. Nice presentation. I'm not sure, once again, if there's any questions, if you can just put them on the chat or raise your hand. So, if you look at the guidelines for HCC in a non-cirrhotic liver, it's in a way it's similar to colorectal liver metastases. It all comes down to the future liver remnant, and if you can resect it with an adequate future liver remnant, then the feeling is that, well, in the guidelines, that you should go ahead. But we know that alpha-fetoprotein is a prognostic marker, and certainly in liver transplantation, we would like the alpha-fetoprotein to be below 500, and we probably wouldn't transplant someone if it was above 1,000. So we were faced with this dilemma of a situation where we had an alpha-fetoprotein of 15,000, and a tumor that was quite big, and we didn't want to wait too long. So we felt, and we that doing a taste and seeing a significant drop in the alpha-fetoprotein suggests that we've got a reasonable prognosis, and that's why we did it that way. One of the things that has come into some transplant guidelines like the Toronto guidelines is biopsying and seeing how or the degree of differentiation of the tumor. And we traditionally haven't biopsied these HCCs, but that's something else that you can, if you're trying to provide sort of personalized medicine, something else that you could consider. So obviously it's early days, and we'll have to see how things go. Ed, I don't know if you have any comments on the case.
Yeah, Mark, I mean, we discussed the patient quite in detail in our meetings here. The one thing is that what I've sometimes have sort of a conceptual problem about is that we use AFP quite rigorously in transplant patients and want to get it down at least below 800 before one would consider it. But at the same time, and the reason for that is not so much that it's a problem with a transplant, is that it's a surrogate for the risk of metastases outside of the liver. And yeah, I mean, obviously we're not taking livers from other patients when we do a resection, but we sort of a little bit on the not consequent, if I say it like that way, how we apply the rule of AFP. And we in this patient we saw quite a nice drop. It halved in about a month, if I'm correct. The half-life of AFP is about 2 weeks, so hopefully it will even go further down. But one of the things that we also thought was that we will resect, and there were also an issue of maybe small lesions on the other side, but we couldn't confirm those, is to taste the other part of the liver that has been shown to have an advantage, a survival advantage, if she now does well and there's hypertrophy on that side. And the other thing is that she could potentially, if she stabilizes and have a prolonged course, even with recurrence, could potentially be a transplant candidate, and that's why we were quite aggressive in harvesting nodes to make that there's nothing outside the liver, at least in the portrait.
Yeah, I mean, I think our experience is that a high alpha fetoprotein, if you provide a regional treatment and it drops significantly, it suggests a better prognosis. If we'd done it and nothing had happened, then you could maybe argue that we shouldn't do a resection and maybe some form of systemic therapy would be better. Mohammed Emelek Hassan has said, for this case, according to Barcelona criteria, the size of the tumor is not for resection. So first of all, the Barcelona criteria is meant for patients with cirrhosis. So like I said, in a non-cirrhotic liver, you can't apply the Barcelona criteria, and the criteria for resection is actually similar to patients with colorectal liver mets. If you can resect it with a adequate liver remnant, that's probably adequate. And I must say, even in the Barcelona criteria, if a lesion is resectable, we would often resect it. The size criterion, I think, mostly apply for transplant when it comes to transplantation. That's my take on it. Are there any other questions? Any other comments? So, I mean, one of the striking things of a lot of the HCCs that we see is how young they are. This patient is in her 20s. And you'll see one of the other cases that we're going to present is also quite young. So I think the next case, Dominic Mutura, who's one of the medical gastroenterologists who's rotating through HPB, is going to present. Dominic?
Can you see my slides?
Yes.
Okay, thank you, Prof. Banon, for the kind introduction. As you've heard, my name is Dr. Mutura. I'm a medical GI fellow here in gastroenterology, Grootes Care Hospital. So I'll quickly recap on a case which we had earlier discussed in one of our last HCC Gecko forums. So it's a 16-year-old young lady with a MELD score of 11, a child pre-score of B7, an alpha fetoprotein of more than 800,000 with a gamma GT of 851 with a relatively preserved liver function in the background of chronic hepatitis B infection. She had a performance score of 1 and also features of portal hypertension. So I'll just quickly run the multiphasic images of the CT for us to be able to appreciate the features which we had actually seen. So just from the arterial phase, we're able to appreciate that she actually had this single lung nodule. And as we're coming into the abdominal view, we're able to appreciate that on the arterial phase, she's having these multifocal liver lesions, which are hyper-enhancing on the arterial phase. Then looking on the delayed phase, looking at the portal vein, we're able to appreciate that there's a tumor in vein with also features of cavernous transformation. And also we can appreciate there's involvement of all liver segments with minimal ascites around the perihepatic area, but predominantly most of the ascites was in the pelvis. And also she did have a splenomegaly. So on the basis of this, we had features of a LIRADS5 multifocal HCC. And initially wanted to post a poll question, but in the interest of time, I'll just read the question. So what would be your management approach to this patient with multifocal disease with main trunk portal vein tumor thrombus with a high AFP, a high GGT, and also extrahepatic disease? So those are the options. Would you test? Would you proceed with systemic therapy, which is either sorafenib or lenvatinib, or would you opt to use an immune checkpoint inhibitor combination, or do you choose best supportive care? I think we can answer this in the discussion. So I'll just quickly mention, we've been talking about guidelines. Here we have the Barcelona Clinic Liver Cancer Staging System, which basically consists of 5 stages, which are dependent on the tumor burden, features of the tumor burden features, the liver function, and also the performance status. So basically, in patients with good liver function who are in BCLC-A, you would proceed with local curative treatments, which will be ablation, resection, or transplantation. And this is informed by the presence of either portal hypertension or the number of nodules and the liver function. Also, those with multinodal disease with adequate liver function fall in category B and should receive chemoembolization. Then basically, what I just want to demonstrate here from the guidelines is that we have multiple tools which can be used interchangeably. Then our patient basically falls under this category C because we have evidence of portal invasion, extrahepatic spread, and she has preserved liver function with a good performance status. So she was a candidate for systemic therapy. So looking at the various systemic therapy, you could either opt for first-line therapy atezolizumab with bevacizumab, or you can proceed to use sorafenib with lenvatinib. But in our patient, we opted to use lenvatinib. The reason for this is because there was a concern of raised portal pressures, and she was at a high risk of GIT bleeding. So that informed the decision as to why we opted to use lenvatinib. So basically here, I wanted to demonstrate the timeline of the approval of the various systemic therapies that we have for hepatocellular carcinoma. So we're able to appreciate that prior to 2007, the multiple trials which had been done on conventional chemotherapies, hormonal therapies, did not seem to show any improved survival in patients with advanced HCC. And most of these therapies prior to 2007 were associated with significant adverse events. So the breakthrough really came in 2007 when sorafenib came into the picture. It marked a new era in HCC. So we had 2 pivotal phase 3 multicenter randomized trials on sorafenib. And for those who don't know, it's a multikinase inhibitor, and it showed that it had prolonged time to progression and overall survival in patients with advanced HCC. And on the basis of this finding, it became the cornerstone really of the management of advanced HCC in the world, despite it having some only modest benefits. So the various trials which have come, you can actually see the names, the resource trial, we also have the reflect trial and the years. And just because we're discussing about lenvatinib today, I'll just mention that it came into the picture in 2018, and the trial that was responsible for that was the reflect trial. So also, I just want to highlight that out of all this, we have 3 therapies which have been approved for as first-line therapies. And so these are basically sorafenib, lenvatinib, and the rest basically, we also have atezolizumab bevacizumab combination, and that was the IMBRAVE trial. Then the rest of these other agents have been approved as second-line therapies. So basically, lenvatinib, we can be able to appreciate that in terms of the overall survival, progression-free survival, it seems to actually be non-inferior to sorafenib, which was actually what it was compared against. So I'll just mention the mechanism of action of the various therapies for advanced HCC. So basically, all of these tyrosine kinase inhibitors work through the various kinases on the surface of the hepatocellular carcinoma cell. And lenvatinib, here it is, it actually works on the surface. It targets this vascular endothelial growth factor pathway, and it leads to this normalization of blood supply, promoting infiltration of these cytotoxic T cells, and also reducing this tissue adhesion molecules, and also increases this antigen presentation. So just quickly to mention the various targets of lenvatinib. It targets this vascular endothelial growth factor 1, growth factor 2, and also growth factor 3. It also targets platelet-derived growth factor, and also HIT. So we know that now it's been indicated for the treatment of unresectable HCC, and it was approved as a first-line therapy. The approval came in 2018, and we know that it's a weight-based dosing. So I'll just quickly talk about the REFLECT trial. So the REFLECT trial was a phase 3 randomized trial, which compared lenvatinib to sorafenib in patients who are treatment naive with hepatocellular carcinoma. And the patients who were enrolled were in child pool class A with an performance status of 0 to 1. And using the Barcelona Clinic liver cancer criteria, they were either in category B or C. So which means that they had this vascular invasion or extrahepatic disease. And basically, we are able to appreciate, that out of sample size of 954 patients who were deemed unresectable, they got a weight-based dose of sorafenib, which was either 12 milligrams once a day or 8 milligrams once a day. And it was seen that it was non-inferior to sorafenib in terms of the overall survival. Also objective response and also time to tumor progression was also longer for patients who are actually receiving lenvatinib. And also the progression-free survival was actually more in the lenvatinib group as opposed to the sorafenib group. In terms of the toxicities, the main toxicity really for lenvatinib was some patients were noted to have hypertension, and also they were noted to develop alopecia. The patients who predominantly had issues of hand and foot skin reactions were predominantly in the sorafenib group. So from all these studies, we're able to appreciate that lenvatinib was actually non-inferior to sorafenib. Then the question now, this begs the question whether or not there's room to expand the indications. So patients who have failed transarterial therapies, it was noted that lenvatinib was more efficacious than sorafenib. And like sorafenib, lenvatinib has also been included as a second-line agent. And also the future shows that some results from this combination of lenvatinib with other immune checkpoint inhibitors are likely to lead to also more improved survival. So we are waiting for studies from that. So in terms of administration, in patients with this unresectable hepatocellular carcinoma, as I mentioned, sorafenib is an oral drug and it's weight-based. So patients who are more than 60 kgs get 12 milligrams once a day. Those who are less than 60 kgs will get 8 milligrams per day. Then it has fairly good renal and hepatic. You can actually use it in patients with renal and hepatic impairment, sorry. And also in those patients who unfortunately develop hepatotoxicity, would have to withhold lenvatinib. And if the hepatotoxicity actually improves to grade 1 or to baseline, and depending on the severity, the persistence, we can either choose to resume lenvatinib or we can actually reduce the dose or permanently discontinue the therapy. So I'll just go back to the case. And what we have here is basically the pre-treatment multiphasic CT and the post-treatment. So basically what I want to demonstrate is, let me get to the abdomen. So basically, let me just time it so that it runs concurrently. We're almost there, okay. So we're able to appreciate that there's actually been a drop in the post-chemo enhancement, and also there's been a reduction in the splenomegaly. And also there's been minimal free fluid post-treatment. This was actually around 45 days after initiating oral lenvatinib. She was less than 60 kgs, so she actually got the lower dose of lenvatinib. And you're able to appreciate that there's actually been a good radiological response. And also clinically, the patient reports that her abdominal pain has actually reduced. She doesn't have any GIT side effects or any symptoms to report. So we're actually quite impressed by the early response that we've seen. The patient is generally well. In terms of her labs, we can be able to appreciate that there's been a drop in the alpha-fetoprotein from 847,000 to around 770,000. And also her gamma GT has dropped from 803 to 751 with fairly good renal function. Her blood parameters are also, full blood count also is within normal. So although the pre-assessment was quite early, we're able to report that she's actually done quite well. So one of the reasons why she ended up getting lenvatinib is that she actually, we managed to actually get some lenvatinib from one of our consultants who was able to get it for her. So I think I can just open it up to discussions right now.
Yeah, thanks very much, Dominic. So one of the issues we wanted to raise was that, you know, if you look in sub-Saharan Africa, the majority of patients with HCC present sort of like this with very advanced disease and are generally for palliative care. This case in particular was very distressing to everyone in the ward because so you have such a young patient and she had such severe symptoms that were very difficult to palliate. And one of our hepatologists had some leventinib left over from a private patient. We had about a 45-day supply. It's not something that is available in the state sector. And most patients with advanced disease in Africa don't get offered these drugs because of the cost, these new drugs. And we went through a stage where we had sorafenib available through trials, and we didn't seem to have very good results. And we didn't feel it was a great loss not to have it. But we gave this patient the leventinib, knowing we only had a 45-day supply. And she's had a very, very impressive clinical response. She's gone from requiring large doses of opiates to not requiring any opiates. And the problem is now that we don't have the drug for her anymore. It would cost, if you got it at a private pharmacy, about 25,000 Rand a month. We're now sitting with a bit of a dilemma on our hands. Ed, any comments?
Yeah, Mark, not on this patient. I think we've discussed this patient before as well. Just, I mean, the sad story that we don't have the drugs that can really benefit a lot of people. Just there was just a comment
I
from.
I see the comment, Joe. Do you want to deal with it, Ed?
Yeah, so honestly, I just mentioned that he's had a few resections for very large non-cirrhotic HCCs, and that the recurrences within a year are very high, especially with high AFP. and then ask about their role, if there are roles for adjuvant therapies. So that's exactly the point, honestly, I think that we made earlier, is that we have to be careful for patients with very high AFPs. It's a little bit of a guessing game, but I mean, we are aggressive with many kinds of therapy because we don't have alternatives, and especially TACE. So if it comes to adjuvant therapy, I think there is some evidence that TACE post-operative has got a survival benefit. So it's not an occlusive TACE. So it's basically just injecting the spheres or whatever you've got into the tumor. And I think that's probably what we're going to do for this patient. And to my knowledge, up to date, there has not been any evidence, certainly not for sorafenib, because there was the STORM trial, that it doesn't make a difference. But I cannot imagine that with the newer drugs that there are not going to be some of them that will definitely show to have a benefit, either as neoadjuvant therapy, adjuvant therapy, or maybe even both.
And
I don't know if you want to say something on it.
Just another thing, Ed, on that. So the immunotherapies like the Atezo-Bev, there's some evidence that after you stop those therapies, you get a sustained immune response afterwards. So you would think that that would also be beneficial after surgery. And, the reason we haven't used those as sort of a neoadjuvant treatment is because they haven't been widely available and we've been using TACE. But if you think about it, you could use a Atezo-Bev, see that the alpha fetoprotein comes down, and that might also provide you with a sustained immune response later. So I think things are going to change, and I think this is one field where we're going to see quite a lot of advances, and hopefully these drugs will become cheaper and more available to us over the next few years. Anasai, do you have anything you want to add?
Thank you very much. I don't have much else to add. My real question really was, these HCCs, maybe a large one in the right lobe, and you do a proper right hepatectomy, the left liver is clear at the time of procedure. Alpha fetoprotein drops from 5,000 to 30. But a couple of months down the line, we've got this disease recurrence. Those are the kind of patients where I was thinking, could there be anything we do before the recurrence occurs? It doesn't seem to be.
Yeah, so well, I mean, like you said, you can actually taste them quite soon after the resection once they've recovered, and you do a taste even before obvious tumors popped up, and then, like I said, maybe give if you could get immunotherapy, give it beforehand, or maybe down the line there'll be evidence to give it later. Who knows? All right. We've got one last case that we just want to present. Malini Bana, one of our other fellows, is just going to present this case. It shouldn't take long. Thanks, Malini.
Thanks, Mark. I'm just going to share. So I'm going to do a case presentation, just briefly talk about indications for liver resection in HCC. So the case that we recently had was a 57-year-old male who presented to us from the Eastern Cape. He was initially seen there at a private hospital and then referred to us after having had a CT scan done for ongoing abdominal pain. So he had a background of being Hep B positive on treatment with a viral load that was lower than the detectable limits. And on the CT scan, we found quite a large right-sided liver lesion, imaging features in keeping with an HCC, as well as a segment 4A lesion. His liver appeared to be non-cirrhotic, and his AFP was 700 at the time of diagnosis. He had quite or relatively preserved liver function, with a child's PUG being A5 and a MELD score of 7. So this is a CT scan. I'll just run through it. You can see the lung fields were clear. There was no evidence of extrahepatic disease. We get down to the liver. You can see there in segment 4A, there's a superficial lesion there. And then the right side is this large hypervascular lesion. for which the right portal vein goes right into. The left portal vein seems spared, and the main trunk, although it is quite close to the tumor, looks quite separate from it. If you follow that down, you can also see that the rest of the liver looks quite smooth. There's no signs of ascites or portal hypertension or any other features to suggest cirrhosis in this patient. So in view of this, we decided to go ahead with a liver resection for him. He had a right hepatectomy where we did a portal dissection, got control of the right hepatic artery and portal vein, and then did a transection as well as a local resection of the segment 4A lesion. Intraoperatively, we also did a bi-leak test through his gallbladder, which didn't show any clear leak. And he did quite well post-operatively, no inotropic support, was extubated and went to the ward. Day two post-surgery, however, a bi-leak was noted in the drain. It was quite low volume at the time, and we decided to just observe it. Around day 4 or 5, he then developed an ileus with normal bloods. His INR and bilirubin were normal at the time. INR was 1.1, bilirubin of 13. His white cell count, however, was in an upward trend. So we started him on antibiotics and did a CT scan done. This is a CT scan day 4 post-op. You can appreciate a large right-sided pleural effusion and a bit of atelectasis at the bases. In that area of his liver resection, you can see a large collection with air locules in it. And the other thing is there's areas of the liver here, segment 4A and B, which are clearly non-enhancing, also with air locules suggestive of necrosis of that area. In addition, if you just look at the left lobe of the liver, there's further areas that are non-enhancing peripherally that are completely separate from the resection area. This portal vein you see going to the left, though, is still preserved and appears patent with good flow in it. So we opted to drain this collection with a CT-guided pigtail catheter that was inserted. I'll just quickly show you what that looks like. So you can see the perc drain coming in and lying in that collection. He clinically improved after this, had a decline in his white cell count and responded quite well. This perc drain was eventually removed, and this patient is now close to discharge. We've just kept him a bit longer, seeing as he is from Eastern Cape and will go back there. And he doesn't have any further bi-leaking. His drain has been removed. We repeated his AFP a month later, and it came back as 35.
Thanks. Oh, sorry.
So just going to briefly mention, in terms of surgical procedures with curative intent in HCC, largely the two accepted ones are liver resection or liver transplant. Liver transplant, of course, being the more oncological acceptable procedure, with 5-year survival rates of around 70 to 80%. That's within the Milan criteria. If we look at liver resection, the recurrence rate is quite high, with up to 70% recurrences noted, and the 10-year survival being 7 to 15%. However, this is largely based on liver transplants done in Western countries, whereas if you look at the broad guidelines across Asian countries, most of the liver resections that are being done are done for patients who are with either intermediate or advanced stage and not early stage disease. So factors to consider, of course, are things like the underlying liver function, the presence and extent of portal hypertension, if they have that, the performance status, tumor characteristics like the size, the number, and involvement of any major vessels. And then, of course, the availability and allocation of organs is important. So if we look at what are the acceptable indications for liver resection in a patient, generally what's accepted in the Western countries is HCC with a non-cirrhotic liver. So those that are Child-Pugh A, ECLC very early or early, so 0 or A. It should be a single lesion, and they should have no clinically significant portal hypertension, varices, or ascites, and have a good performance status. However, as I mentioned, most of the resections that are done in the real world are for more than 50% at least are for intermediate and advanced stage patients that fall outside of these criteria. So I'm not going to go through those, but just to compare that to the Eastern guidelines, if you look at the Japanese and other Asian countries, they consider patients for resection with, if it's a single HCC of any size, regardless of vascular invasion. If there are multiple nodules, within 3 in number, and then they extend the criteria to Charles-Pugh A and B. If you look at the Korean guidelines, they look at anybody who has curatively treatable disease with no limit regarding the tumor burden itself. So the Asia Pacific guideline recommendations are, if you have a patient with a Charles-Pugh A that is non-cirrhotic, liver resection should be the first line of treatment if this patient is resectable, as discussed by an MDT. Liver transplant, on the other hand, is the best curative treatment from an oncological point of view and is first line for Charles-Pugh B and C patients if the liver graft is available. And I think this just reflects the paucity of transplants of liver grafts, available in these countries, and the more readily available surgical options that are there. And I think I'll just end it there and open it up to discussion.
Thanks, Melanie. That was very good. Yeah, so I think, in this patient, the alpha-fetoprotein was only 700. And also the patient lives far away from us. So that was one of the reasons why we decided not to go with the TACE option first. And then, I think it's useful just to show some of the complications that you get after liver resection. And we had 2 things that were wrong. We had a collection and we had a bit of liver that was necrotic. And the decision was made to drain the collection, which was a much less invasive option than going back and resecting that additional liver. And actually, once the collection was drained, the patient was fine, and we haven't had to do any further surgery, and the patient's doing very well. So my understanding of the data from the West, Western countries, is that after 5 years, the survival rate between transplant and resection is the same. But after 10 years, there's a much improved survival for patients who have a transplant, and that's because of the recurrent HCCs. I wonder whether that applies to non-cirrhotic patients. And these patients that we've had who are non-cirrhotic, who are now on Hep B treatment, might have a lower recurrence rate than cirrhotic patients. But that's just I'm not sure about that, but maybe. Anyway, I don't know if there's any other questions or comments.
Mark, just one question on this patient. Are we going to taste this patient?
Yes, we're planning to do it. So we're planning to send the patient home now, and we're going to get him back in January. We're going to rescan him, and then even if there's not a recurrence, we're planning to taste that liver remnant. But we just want him to settle down. He's got that necrotic segment 4, and just see how things go. Yeah, and then if anyone has any ideas or has any experience in crowdfunding, we really are desperate to try and raise some money for the second case that we presented, that young girl, because we're in a bit of a predicament at the moment where we don't have any further treatment, and she's responded so well to the treatment she's had. So thank you to the speakers, and thank you to the HCC University of New Mexico and HCC India team. The recordings of this will be available on the Gastro Foundation website. Thank you to the Gastro Foundation, and thank you to the sponsors of the Gastro Foundation. Next week's presentation will be on patient blood management. I think that is the last HCC GECO meeting for the year. So thank you very much for everyone who's supported these throughout the year. Thanks.